Welcome back to the deep dive, where we take the most complex science that underpins modern medical practice and really try to distill it down to the core, memorable insights you need.
And today, we are undertaking a really fundamental deep dive. It's crucial for anyone in perioperative
Right, I
care.
was going to say, this is the bedrock.
It is. The basic principles of pharmacology. Our whole mission here is to transform these concepts that, they feel like they're stuck in textbooks. Things like clearance, context-sensitive
For
halftime,
those terms, yeah.
and turn them into practical knowledge for precision dosing.
Okay, let's unpack this because this isn't just theory, is it? This is
Yeah.
the difference between a smooth anesthetic and a really rough one.
Absolutely.
We're looking at what you call the two great pillars of pharmacology, pharmacokinetics, or PK, and pharmacodynamics, PD.
That's it. These two concepts, they define the entire practice of giving drugs safely.
So how should we think about them?
Well, you can think of it as a two-part conversation between the body and the drug. It's a back and forth. So Pharmacokinetics, PK, asks, what does the body do to the drug? This covers absorption, distribution, metabolism, and excretion.
Right.
It's all about the relationship between the dose you give and the concentration of that drug in the plasma over time.
And the other side of that coin?
That's pharmacodynamics, or PD, it asks. What does the drug do to the body?
Ah, the effect.
Exactly. It's the concentration to effect relationship. What happens when the drug actually gets to its target, like the brain for hypnosis or, the spinal cord for analgesia?
So PK is the delivery and PD is the impact.
You got it.
And I guess if you miscalculate the PK, the delivery part, then the PD is completely unpredictable.
That's why understanding them together is so essential. Anesthesia is basically applied drug math, but for a target that's always moving.
All right, let's start with the delivery system then. Let's get into the PK.
Let's do it.
When we talk about PK, we have to start with the concept that I think confuses people the most. The volume of distribution, or VED.
It is a tricky one.
Let's frame it with a clinical problem. Why is it that when you push a huge dose of a drug like fentanyl, you end up with only a tiny concentration in the blood? Where does it all go?
That question points directly to VED. You see, VED is defined as the apparent size of the tank, the container, into which a known dose of a drug distributes to give you a measured concentration.
Okay, so it's just an equation, dose divided by concentration.
Exactly, but the key word there is apparent. Our body has a fixed physical volume, right? But the VED can be massive, and that tells us where the drug has gone.
You're saying that if we inject, say, 100 milligrams of a drug and measure a concentration that implies it's dissolved in 400 liters of water,
Then the VED is 400 liters.
even though the human body is only, 70 liters?
Precisely. That huge apparent volume tells you that the drug isn't staying in the plasma. It's rushing out of that central compartment and distributing widely into peripheral tissues.
So let's take that fentanyl example.
It's a dramatic one. Fentanyl's VED is around 4 liters per kilogram.
No.
So if you have a 70-kilo person, that's 280 liters of apparent volume. Now, compare that to the actual vascular volume, which is tiny, maybe 0.07 liters per kilogram.
So that massive VD for fentanyl just means it's extremely lipid soluble and it's binding to tissue all over the place.
That's it. The VED isn't a literal space. It's a quantitative measure of how much drug leaves the blood and binds to everything else. Fat, muscle proteins, you name it.
And that's the crucial insight for the practitioner, right?
It is. The larger the VED, the more drug is basically sequestered, hiding in those peripheral tissues.
Like a reservoir.
A huge reservoir. And that reservoir critically influences how long it takes for the plasma concentration to fall back down to a level where the patient can wake up. That sequestered drug will leak back out, slowing everything down.
Okay, so if VED defines the size of this apparent container, then clearance, or CL, that must define how fast we're draining the drug out.
Perfect analogy. Clearance is the rate of drug removal from the plasma, and we express it in units of flow, so volume per time, like liters per minute.
And why is it important to use flow, not mass?
Good question. We have to distinguish clearance from the elimination rate. The rate is measured in mass per time, like milligrams per minute.
And that changes.
It changes constantly. If you have a high drug concentration, the liver works fast. If it's a low concentration, it works slow. The rate is variable.
But clearance, at least in first-order kinetics, which is most of our drugs, is constant.
Yes. Clearance reflects the body's inherent fixed capacity to remove the drug. It's independent of the concentration at any given moment. at least until you saturate the system.
And it lets us calculate steady-state concentrations for infusions.
It does. The infusion rate has to equal clearance multiplied by the target's steady-state concentration. It's the balancing act.
So let's look at the plumbing itself. How do our organs, like the liver and kidneys, actually do this? There's a formula, right? Clearance equals organ blood flow times the extraction ratio.
And that one formula is so powerful because it splits all our anesthetic drugs into two radically different categories.
The flow-limited drugs and the capacity-limited drugs.
Exactly.
Let's start with flow-limited. What does that mean?
In this case, the extraction ratio, or ER, is nearly 1. That means the liver's so efficient it removes almost every single drug molecule that flows through it on the first pass.
So the liver's metabolic machinery is just overwhelming.
It is. So the bottleneck, the rate-limiting step, is simply how fast you can get blood to the organ.
And the classic example is propofol.
Propofol is the prime example. Its clearance is almost entirely dependent on liver blood flow. And here's the clinical takeaway, though, why this matters.
Go on.
If your patient goes into shock or has a severely reduced cardiac output, their liver blood flow plummets.
Right.
If that blood flow drops by 50%, propofol clearance drops by 50%. And if you don't cut your infusion rate in half immediately, that patient can be instantly dangerously overdosed.
Wow. So blood flow, the Q in that equation, is everything for propofol.
It's the rate-limiting step.
That's a huge risk, especially in hemodynamically unstable patients. But then we have the opposite, the capacity-limited drugs.
These are the inverse. For capacity-limited drugs, the extraction ratio is low. The drug flows through the liver, but the liver only manages to extract a tiny fraction.
Why?
Because its metabolic enzymes, like the P450 system, are slow, or there just aren't enough of them for that particular drug. Alpha-fentanyl is the classic example here.
So if the enzymes are the bottleneck, the rate-limiting step, then changes in liver blood flow shouldn't matter as much.
They have a minimal impact, right? For alpha-fentanyl, what matters is the hepatic function itself. Does the patient have severe liver disease that reduces the number of enzymes, or has some other drug induce the enzymes, increasing their activity?
I see. So a drop in cardiac output won't change alpha-fentanyl clearance much.
It's negligible. Because the liver was only extracting, say, 10% of the drug anyway, the metabolism itself, the biotransformation, is the key variable here.
And speaking of biotransformation, the liver does most of the heavy lifting with oxidation, reduction, all that. But we have to mention the outliers, the ones that don't rely on the liver.
We absolutely do, because they give us incredible clinical leverage. Their clearance is highly reliable, even if a patient has liver or kidney disease.
So we're talking about drugs like remifentanil?
Remifentanil, succinylcholine, esmolol, they're all cleared by ester hydrolysis that happens just about everywhere in the plasma and tissues.
So it's not concentrated in one organ that can fail.
Correct. And then you have drugs like pancuronium, a muscle relaxant, that relies heavily on the kidneys for excretion. Knowing these exceptions is critical when you're managing a patient with multi-organ failure.
Okay, so to manage this whole complex system, we have to rely on models. The source material mentions two types, these very complex physiologic models, and then the more practical compartmental models.
Right. The physiologic models are, they're mathematically beautiful. They try to map out blood flow to every single organ, but they're clinically impossible to use in real time.
Too cumbersome.
Way too cumbersome. So we use empirical compartmental models. These are simpler. They just use mathematical exponents to fit the decay curve we actually see in the plasma after we give an injection.
And the number of compartments, 1, 2, or 3, that just corresponds to how many exponential terms you need to describe that curve accurately.
That's all it is. And most of our anesthetics follow what we call first-order kinetics.
Which means the rate of elimination is proportional to the concentration. More drug, faster elimination.
It's the norm. But we always have to watch out for zero-order kinetics. That's where the body's metabolic pathway gets saturated.
And then what happens?
Then the drug is eliminated at a constant rate, no matter how much more drug you add. It's dangerous because concentrations can just shoot up exponentially.
Leading to unexpected toxicity.
Exactly. While most anesthetics are first order, a massive overdose can push them into that zero-order danger zone.
So let's visualize the most common model we use in anesthesia, the 3-compartment model. We have the central compartment, V1, which is the plasma, then a rapidly equilibrating one, V2.
Highly perfused tissues like the brain and muscle.
And a slowly equilibrating one, V3.
Right. Poorly perfused tissues like fat and bone.
So if we use a hydraulic analogy like water in tanks, what happens right after a bolus injection into V1?
You see 3 very distinct phases. as the concentration in V1 falls.
Okay, phase 1.
Phase 1 is the rapid distribution phase. This is the steepest drop on the curve. Drug is just rushing out of V1 into the two peripheral compartments, V2 and V3, and at the same time it's being removed by systemic clearance, the drain.
So it's leaving in all directions at once?
Which is why the drop in plasma concentration is so dramatic.
Okay, then what's phase 2?
Phase 2 is the slow distribution phase. This is where the curve starts to flatten out quite a bit. The concentration in V1 has now dropped below the concentration in that rapid compartment, V2.
So what happens? The flow reverses.
Exactly. Drug starts returning from V2 back into V1. This influx acts like a momentary backwash, and it slows down the rate of decline in V1.
So the decline looks slower than the actual elimination rate because the plasma is being reloaded from the periphery.
You've got it.
Yeah.
And that leads to phase 3, the terminal elimination phase.
Okay.
Now, the V1 concentration is lower than both peripheral compartments. So drug is returning to the plasma from both V2 and that vast, slow V3 compartment.
And the only way out is still that one drain, the systemic clearance?
That's the only permanent exit.
Yeah.
So this return flow from the peripheral sink just vastly, vastly slows the rate of concentration decrease. This final, shallow slope is what's defined by the terminal half-life.
Wait, I need to pause you here. This is a huge source of confusion.
It is.
If the terminal half-life of a drug like fentanyl is, say, 8 hours, does that mean our patient is going to be asleep for 8 hours after one shot?
That is a fantastic question, and it's probably the most critical takeaway from this part of the discussion. The answer is no. The terminal half-life sets the absolute upper limit, but the actual time for the concentration to fall to a clinically relevant level, the level where the patient wakes up, is determined by that initial rapid distribution phase.
So the drug's effect stops not because it's been eliminated,
but because it has rapidly redistributed out of the central compartment and into V2 and V3. For a single bolus, the terminal half-life is often completely irrelevant for predicting recovery time.
That is a game-changing concept. Okay, so speed is everything. Let's talk about the kinetics of onset and offset. Front-end kinetics, the moment of onset. Standard models assume instant mixing, right?
They do, to simplify the math. But physiology gets in the way of the math.
How so?
When you inject a drug into an arm vein, there's a delay. It has to travel to the heart, through the lungs, and then into the arterial circulation that feeds the brain. The drug doesn't show up in the radial artery for about 30 to 40 seconds.
And that initial circulation time, plus the recirculation that follows, that must profoundly influence the peak concentration that you actually see at the effect site.
It does. This is why you have to wait after giving an induction bolus. You're waiting for that initial phase of distribution to happen. You need more sophisticated recirculatory models to predict that sharp peak accurately.
So on the flip side of that, we have back-end kinetics, which is all about waking the patient up.
Emergence, right. We
Yeah.
use the concept of decrement time. That's the time required for the plasma concentration to fall to a specific target level after you stop the infusion.
And the famous metric here is the context-sensitive half-time, or CSHT.
The 50% decrement time.
And the context-sensitive part is key. It refers specifically to the duration of the infusion.
Yes, the duration matters immensely. It's because the drug accumulates in those peripheral tissues, in V2 and V3, over time. Think of the peripheral tissue as a giant sponge.
Okay.
If you run an infusion for just 20 minutes, the sponge is only slightly damp. The CSHT is short. But if you run that infusion for 10 hours, the sponge is completely saturated with drug.
So when you turn off the main drip after that 10-hour case, that saturated sponge starts wringing itself out, dripping drug back into the plasma.
And that sponge drip makes the drain, the clearance, almost useless for a long time. That's what makes the context-sensitive half-time so much longer after prolonged infusions.
That makes perfect sense. Propofol is known for having a relatively short CSHT.
It does, even after long infusions. But other drugs, some benzodiazepines or opioids like fentanyl, show dramatically extended CSHTs when given for hours, precisely because of that vast, saturated peripheral reservoir feeding back into the circulation.
Which brings us to a final crucial disconnect, hysteresis. We know the drug is in the plasma in V1, but we don't see the effect in the patient immediately. There's a lag.
Hysteresis. It describes that time lag between the peak plasma concentration and the actual peak drug effect, which you might measure with a brain monitor.
So because of that lag, a single plasma concentration could correspond to two different effects.
Exactly. If concentrations are rising, a concentration of, say, 2 gives you one level of effect. If concentrations are falling, that same concentration of 2 gives you a different, deeper level of effect. It creates this predictive loop.
So how do we solve that clinically? It sounds like a mess.
Pharmacologists solved it by inventing a conceptual tool, the effect site compartment, or C.
So it's not a real place.
It's a virtual space connected to the plasma compartment designed specifically to model this time lag. It has a negligible volume, but it has one vital parameter, the key rate constant.
So the key is basically the speedometer for the drug getting from the blood to the brain.
That's a great way to put it. It defines the rate of movement into and out of the effect site. A large key means fast equilibration. The drug gets to the brain quickly, the effect comes on fast and goes away fast.
And a small k means a slow lag.
A very slow lag. This constant is fundamental for predicting the speed of induction and, more importantly, the speed of emergence. It's our best real-time predictor of the clinical effect.
Okay, so we've established the delivery system, the PK. Now we have to move to the impact, the PD. When the drug finally arrives at the brain, what happens?
We model this using what's called the sigmoid Emax relationship, or the Hill equation.
Which is that S-shaped curve you always see.
It is, and that curve plots the concentration at the effect site, C, versus the resulting effect.
Yeah.
It gives us three crucial parameters.
Okay, what's first?
First, you have Emax, the maximum possible effect, and E0, the baseline effect before you gave any drug. Second, you have C50.
C50, the concentration needed to get to 50% of that maximum effect.
Correct. And the third parameter is gamma, or the Hill coefficient. That defines the steepness of the curve.
So a high gamma means a very steep curve.
Very steep, which means a tiny change in drug concentration results in a massive change in the clinical effect. This defines a drug's dynamic range, that narrow window where concentration changes are really meaningful.
This brings us to a really important distinction: potency versus efficacy. In simple terms, I always think of it as I can use a whole tablespoon of something weak or just a single drop of something potent.
That's a perfect analogy. Potency is measured by the C50. A lower C50 means you need a smaller concentration to get to 50% effect, so the drug is more potent.
So if we compare the fentanyl family of drugs.
A great example, sufentanil has a C50 that is orders of magnitude smaller than alfentanyls. It's vastly more potent by concentration.
But efficacy is different. That's just the Emax, right? The maximum possible effect the drug can achieve.
It is. Whether I use a potent or a less potent drug, if they're both full agonists, they can both get you to the same maximum effect, the same Emax. A partial agonist, on the other hand, can never reach Emax, no matter how high the dose. It has lower efficacy.
Now, here's where the clinical risk comes in. A single drug has multiple effects, and each of those effects has its own C50.
This is so critical. The source material shows that for fentanyl, the C50 for analgesia is around 2 nanograms per milliliter.
Okay, that's our desired effect.
But its C50 for ventilatory depression is only slightly higher, around 4. And the C50 for full unresponsiveness to something like laryngoscopy is way up at 15.
So you achieve your target analgesia at 2, but you are just a tiny concentration increase away from a severe side effect, respiratory depression, at 4. That proximity is the safety margin.
Or lack thereof. The narrowness of that gap between the therapeutic effect and the toxic effect is everything. And we quantify this with the therapeutic index, or TI.
Which is the lethal dose 50 divided by the effective dose 50.
LD50 over ED50. A larger ratio means a wider safety margin, a safer drug. And the reality is that many of our anesthetic drugs have distressingly narrow therapeutic indices, which demands incredibly precise titration.
And the reality of anesthesia is that we rarely use a single agent. It's almost always a polypharmacy cocktail, a hypnotic, an analgesic, a muscle relaxant.
Anesthesia is the practice of applied drug interactions. We categorize them as additive, which is 1 + 1 = 2.
Synergistic, where 1 + 1 is greater than 2.
And antagonistic, where 1 + 1 is less than 2. Synergy is what makes modern anesthesia so efficient and, frankly, safer.
And the visualization tool for this synergy is the Isabelli's, the ISO effect line. I find this concept just fascinating.
It's a great tool. An isabelle is a line on a graph that represents all the combinations of two drug concentrations, X and Y, that produce the exact same effect, say a 95% probability of immobility.
So if you draw a straight line between the C50 of drug X alone and the C50 of drug Y alone, that's additive.
That theoretical straight line is a perfect added interaction. But if the actual isoeffect line bows inward toward the origin of the graph,
That means you need less of the combination than the simple sum would suggest.
which confirms synergy. You've got it. The clinical goal is to find the best combination on that 95% isobole. You use lower doses of both agents, you get the combined effect, but you avoid the side effects of a high dose of any single agent.
Less hypotension, faster recovery.
Exactly.
And the source material has a great summary of the key patterns. Inhaled agents, when you combine them, are almost strictly additive.
They are, which suggests they probably work through a similar final pathway. The one exception is nitrous oxide, which can be a bit infraadditive,
But the really powerful combinations, the ones that define modern anesthesia,
are the synergistic ones. An IV drug plus an inhaled agent, primarily synergistic. An opioid plus a sedative hypnotic like propofol and remifentanil.
highly synergistic.
Highly synergistic. This is why the combination is so powerful. You're hitting different targets at the same time and magnifying the effect.
And this isn't just theory anymore. This knowledge is what's driving the development of drug displays.
Drug displays are the crucial clinical application of all this PK/PD theory. They take incredibly complex 3D mathematical data, concentration X, concentration Y, probability of effect, and they present it in a visual format right at the bedside.
That's revolutionary. It means you're not just guessing based on blood pressure. You have a real-time prediction of the effect site concentration and the calculated probability of unresponsiveness.
The advantages are huge. You can run a simulation before you even give the drug. And even if you don't have an official target-controlled infusion or TCI pump, they allow for what we call passive TCI.
Guiding your manual infusions.
Exactly. You're guiding them toward a specific evidence-based target like a 99% probability of effect, instead of just chasing an arbitrary number like in Massey.
Okay, we have laid all this theoretical groundwork. Now we have to move into the clinical reality where the population models start to break down and we have to individualize.
This is where the art meets the science.
Let's start with perhaps the most challenging demographic to dose correctly, the obese patient.
The primary challenge in the obese patient is purely pharmacokinetic. If you dose based on total body weight, TBW, you're taking a huge risk.
Why?
Because the high percentage of adipose tissue changes both the volume of distribution and the clearance, but it changes them differently for every single drug. We have to use specific weight scalars.
So we're choosing between ideal body weight, lean body mass, corrected body weight, all of them. And the right one depends on the drug and whether we're giving a bolus or an infusion.
Let's use propofol as our main example.
Yeah.
It's highly lipophilic, so it likes fat, but it's also a flow-limited drug, and clearance actually increases in obese patients because they have larger livers and more blood flow to them.
That creates a real dosing dilemma. So if we dose the propofol induction bolus based on total body weight,
You are asking for catastrophic hypotension. Absolutely. The recommended scalar for the bolus is lean body mass, LBM,
and why is that?
because the rapid initial distribution of the drug is confined to the highly perfused lean tissues, the brain, the muscles, and those aren't proportionally larger in obese patients. Dosing by TBW massively overestimates that initial distribution volume.
Resulting in a huge, excessive peak plasma concentration.
Profound hypotension.
But then for the infusion, for the maintenance phase, we have to switch gears completely.
This is the crucial switch. For maintenance, you must transition to dosing based on total body weight or a corrected body weight.
If you stick with LBM,
You risk underdosing,
Yeah.
and the patient could potentially have awareness. The reason is that higher clearance capacity, that increased liver blood flow, is metabolizing the drug faster. You have to increase the infusion rate to match it.
so LBM for the bolus to prevent overdose, TBW for the infusion to prevent underdose. That's the key takeaway for propofol.
It truly is. And it's also why standard TCI models like Marsh and Schneider can struggle. Their data sets didn't include many obese patients. The source points to the leveled model as being superior because it uses allometric scaling across a huge data set, so it gives much better predictions.
Okay, now let's turn to opioids, specifically remifentanil, which is the gold standard for intraoperative infusions. It's a completely different calculation.
It is. Remifentanil is unique. It's cleared by those nonspecific esterases in the plasma and tissues.
So the amount of fat tissue doesn't matter.
It doesn't affect the distribution volume or the clearance rate. Its PK parameters are remarkably similar between lean and obese patients.
So if the fat mass is pharmacologically inert, we should dose it based purely on the metabolically active tissue.
Exactly. The recommended scalar for remifentanil is fat-free mass, or FFM. If you dose by FFM, you get effect site concentrations that are very similar to what you see in lean patients dosed by their total body weight.
And if you dosed by total body weight in an obese patient?
You would be wildly overdosing.
What about other lipophilic sedatives, like midazolam?
Midazolam shows yet another mixed pattern.
Mm-hmm.
Its volume of distribution is increased with obesity, so the initial bolus needs to be scaled by total body weight to fill that larger volume.
Okay.
But its clearance is fixed. So for a continuous infusion, you should scale it to ideal body weight to prevent it from accumulating over time. The takeaway is that every drug is different. You have to know its specific PK profile.
So if obesity is primarily a scaling problem, a PK problem, then aging is a much more complicated mix of slowing down, which is PK, and increased sensitivity, which is PD.
It's a dual challenge. Elderly patients require vastly reduced doses for two major reasons.
Let's start with the PK changes.
The pharmacokinetic changes are driven by cardiovascular aging. Reduced cardiac output is a given, which means slower circulation time. That slower circulation delays drug redistribution.
And that paradoxically leads to a higher initial peak concentration.
It does. The bolus sits in the central compartment, in V1, for longer before it can distribute. Higher peak concentration means a higher risk for adverse events, like hypotension, right at induction.
And clearance is also down.
Yes. Decreased blood flow to the liver and kidneys means reduced clearance for drugs like propofol, leading to a prolonged duration of action. The drain is just working slower.
But the even more dramatic change is on the PD side, increased brain sensitivity.
The aged central nervous system simply requires less drug concentration to achieve the same effect. And the quantitative data here is striking.
How much of a reduction are we talking?
To get the same effect as in a 20-year-old, an 80-year-old patient requires about 65% less propofol and 55% less remifentanil.
That is a massive reduction, not a subtle adjustment.
It's a foundational reduction, driven by both PK slowdown and PD sensitivity.
And this forces us to move beyond just their chronological age to the concept of physiologic age.
We have to. An 80-year-old marathon runner is going to handle a drug very differently than a frail, sedentary 80-year-old with multiple comorbidities.
So you're titrating to their overall health status.
Their cardiovascular function, their exercise tolerance. That's what guides the dose reduction, much more than the date on their birth certificate.
Okay, let's synthesize all of this. Let's walk through the two extreme clinical scenarios from the source material. This is where the theory becomes a roadmap.
Let's do it.
Case 1, the obese patient. We have a 45-year-old male, 185 kilos, BMI of 60, in for gastric bypass.
A very common scenario.
The central challenge is all about managing those PK changes. We're navigating the risk of immediate overdose and hypotension versus the risk of underdosing later and having awareness.
Right. So our strategy for propofol has to be biphasic. For the induction bolus, we use lean body mass.
Prioritizing hemodynamic stability.
Exactly. We avoid dumping too much drug into that relatively small central circulation. But then for the maintenance infusion, we have to acknowledge his increased metabolic engine.
So we scale the dose higher.
We have to. We switch to using total body weight, or a corrected body weight, to match his expected higher propofol clearance.
And for remifentanil, it's simpler.
Much simpler. Its clearance is fat independent, so we dose it purely based on fat-free mass. This whole case revolves around picking the right PK scaler for the right drug at the right time.
Now, case 2, the elderly patient. An 80-year-old female, 55 kilos, reduced cardiac output, in for a hip replacement. The problem here is fundamentally different.
The core challenge is that combined PD sensitivity and global PK slowing. We have a brain that's hypersensitive to the drug, combined with a delivery system that's slow and a clearance mechanism that's impaired.
So the strategy has to be a drastic overall dose reduction. We're talking 55 to 65% less drug compared to a young adult.
We are. And we have to anticipate the PK risks from that reduced cardiac output. First, a delayed onset, which requires patience. You can't keep re-A-dosing.
Right.
And second, that higher initial peak concentration, which demands a slow, carefully titrated bolus to avoid causing severe hypotension.
And this is where that physiologic age concept is front and center.
It's everything. If this patient is frail, we lean toward that 65% reduction. If she's robust and active, we might be able to tolerate a slightly higher concentration, but we're always starting low and going slow.
Comparing these two cases really provides the ultimate synthesis, doesn't it? They are the opposite extremes of PK and PD influence.
They are. The obese patient's challenge is primarily a scaling problem. It's a PK challenge. We're adjusting for VD and CL. The clinician is essentially solving complex compartmental math in real time.
Whereas the elderly patient's challenge is fundamentally a sensitivity problem, a
Mm.
PD challenge, that's combined with a system slowdown.
Exactly. The brain is more sensitive, and the capacity to clear the drug is diminished. The dose reduction is because of an altered response at the target organ, not just a failure to scale the dose correctly.
But the common thread, the thing that ties this entire deep dive together, is the necessity of individualization.
We have to abandon the one-size-fits-all approach. Safe anesthesia requires understanding a drug's fundamental PK/PD profile and then adjusting your strategy to that specific patient's unique physiology.
We've spent this time trying to transform these complex principles, VD, CL, KZ, CSHT, into clinical decision rules. Understanding them lets you predict drug behavior, moving beyond just guessing.
And we are now entering an era where technology is making this kind of precision commonplace. These complex mathematical principles, they're now being visualized in real time through drug displays.
It's taking the theory from the textbook to the bedside.
It translates the theory of PK/PD into immediate actionable intelligence for safer titration.
So the integration of the scientific rules with the skilled judgment of the practitioner, the art of titration, that's what really defines modern, safe perioperative care.
It is. So think about the next time you start a propofol infusion or give a
Mhm.
fentanyl bolus. Will you still be relying on simple half-life figures? Or will you fundamentally shift your focus?
A compelling thought.
Will you actively use these predictive models to understand the context-sensitive halftime and the effect site concentration, especially during those critical moments of induction and emergence for a complex patient? That continuous integration of science and skill. Well, that's the mark of expertise.
A truly compelling thought to reflect on. Thank you for joining us for the deep dive. We'll see you next time.